Thank you very much, Pradeep, Manish, Vinay, and Dr. Devshish for having me here. I think this is a very, very important talk for all of you. I was listening to a couple of postgraduates, and this is not just today, for quite some time. कितने कर लिए? अरे, I have done 50. I have done 100. I have done 150. They are only talking of cataracts and nothing else. It seems our entire postgraduates, even if we want to teach them something else, they are only concentrating on doing the cataracts. Well, I have some news for them. The moment they come into the practice, and most of the practitioners here would realize that there is hell of a lot of things happening. First, everybody is doing a good cataract, so you are nothing unique at all. It has so much seasonal variation, especially in Delhi we see. Sometimes it's cold, sometimes it's too hot, sometimes it is raining, sometimes it is exams of the children. So it's got a lot of variations, and if you put your practice entirely into cataract's hand, then a lot of time your practice would be empty. Beyond that, do you know there were more than 15,000 people thrown out from in Bangalore who were in high-paid, high-tech jobs, which were these jobs of software, because the technology changed so fast that suddenly they were redundant. So please be careful with the advent of femtocataract. I'm really worried. I am telling you the truth is that sooner or later they are already doing all the things. They are making the incision, they are making the capsulotomy, they are doing the rexes, they are doing the emulsifying the whole lens. All they now need to do is put in 2 tubes from the sides by a robo, and the whole thing will be done. You will be just standing on the side, and the cataract will be gone from the armamentarium of ophthalmologists. Please be aware of that. And I am telling you that time is not far away, and that is why you need to concentrate on glaucoma. So I know that glaucoma surgery is a no-win situation for us. Doctor is unhappy, patient is unhappy, there's little money, but we are not talking about that. Everybody has told you over here in the previous lectures, but I'll put it short. Every 1 in 8 patients walking past your clinic, entering your clinic above 40 years of age is either having glaucoma or is a glaucoma suspect. If you can't catch it, it is your trouble. Plus, cataract patient will come and go, but glaucoma patient is for life. Most of them, and this you will have to impress upon them, that most of them will require 2 to 3 monthly IOP check. Every 6 to 9 months they will have to have a visual field check, and finally they are going to develop cataracts as well. Many of the accompanying patients will be sitting with them, and they'll be seeing your posters, and they might get lured into getting the other procedures done, which would be LASIK, cataract, or even checking for diabetic retinopathy. Most postgraduates have the basic skills. The trouble is they are only concentrating on cataracts. So you have to be alert. I think beautifully everybody has told you how to catch these patients from the early disc. And please remember, 50% of the patients when they walk into our clinics have normal pressures even when they have glaucoma. So don't go on to that. Disc is the clinical clinching point. So please examine all your patients by dilating them. And you need to be alert to check up the system. I see hundreds and thousands of patients. Most of them have come to me after they have been to at least 5-6 doctors. And very few have ever been told what is glaucoma. So please take some time, especially if it's a newly diagnosed patient. Sit down with the patient, spend 5 minutes, tell him what the hell is this disease. Show them normal disc and photograph, and I can tell you my practice has gone up by 30% after using this. All of you have laptops. Just take the laptops, fill in some of the images of a normal disc, abnormal disc, and if you can take the photograph of the patient itself, it's a panacea. It is beautiful. What is a visual impression? You will never be able to explain to the patient in your words. Never. He's never impressed. If you just show him that, all right, your disc was this, it is coming like this, and ultimately it may become like this. The shock for him is really indeed something true. Besides that, we do know that if the patient is glaucomatous, you need to check all the relatives of the patient. And this you have to impress upon. I tell him it is your responsibility to get all the patients checked. Luckily, I don't have time to see all that, but if you don't have a busy practice, you can tell them, yes, bring them to me, and I will check them. So you have another group of patients following you up. So it brings in more patients, and some of these relatives may not have glaucoma, but they may have something. So explain to them that this is the structure of the eye, this is how the block occurs, this is how an open angle or a closed angle looks like. Explain to them in some details, and then the optic nerve will get ultimately affected, and this is how your vision will go down. Show this to them in visual images. Again, now what Tanuj was talking about and Ramakrishna, that most of the people in our country are not well off. The ones we are sitting here are perhaps top 2% of the country. The rest of the people have a hard time making two ends meet. So please, every bit of money for them is value. So please explain each test to them. Fields, I know it's a difficult test, but it's a must test for us. And indeed, we know that only 14% of fields that you do first time are going to be okay. The rest will have to be repeated. So either you get the component of that money into that, or have the courage to do the next fields free, because you will have to get two fields which are consistently same before you really make your baseline. Explain to them that unless I do a visual field, I cannot decide what kind of pressure I need to keep in you. If the fields are bad, I need to keep a lower pressure. If the fields are not that bad, even 20 pressure is okay for you. Then he will understand, yes, this is the importance. Plus, you tell them that, yes, I will do these repeatedly after 9 months to 1 year, and we can see whether you are progressing or not. I can add on medications to you, but this needs to be explained to the patient with the fields in this. Again, the element of pachymetry. And in pachymetry, many times when I go to small places, people ask me, sir, pachymetry, we don't have it. If I send to somebody else, the patient will be gone to that doctor. I am finished. So I tell them, yes, at least for some patients, you really need it. It's a must. If it's an ocular hypertensive, you need a pachymetry. If you are a normal tension glaucoma, then you need it. If again, in these situations, it's a must. But by and large, you can sometimes even go without it. But please, everyone can buy a gonioscope worth 6,000 to 8,000 bucks. And like somebody had told, you have to practice this. You have to practice it. Do it in each and every patient, so that the moment you see an abnormal angle, you will be able to detect it. And 50% literally, though when I was going on a lower side, by and large, at least 1/3 of your patients would definitely be angle closure. And if you miss angle closure, the next doctor is going to catch it. You are going to look very fine in the eyes of the patient or the doctor. Plus, you have missed treating the primary thing. Plus, you missed the making money by doing a peripheral iridotomy. So you are a loser all the way. So please do a gonioscopy repeatedly. 40% of the progressions were caught in all the major studies by doing photography. All right, it was a 3D disc photography and whatever. But at least if you have the capability to do a fundus photograph, in all my patients I dilate this thing and do a fundus photography. Many a times collaterally you can find out so many other retinal defects. So please make it as a routine if you can do it. And so you can, as far as this part is concerned, I think everybody, and Tanuj had very rightly said, I am sick of seeing patients being treated for the red disease. Nothing is wrong. Not only that, for God's sake, do not do OCT in patients who are literally blind. People with advanced glaucoma, what the hell are you trying to look in the OCT? So please use this nerve fiber analysis with great care. It is expensive. So primarily use it in patients where you are confused, in ocular hypertension where you know whether treatment is required or not. If you don't have machines, please try and pool together your resources. I saw in Indore 18 doctors get together and pool their resources in a common place and get them to buy all the machines. That was really great. So get together and find basic fields would be fields, pachy and lasers that you will require. So please develop glaucoma screening. It will assure your bread. Cataract would be and LASIK will be for your butter. Thank you.